SAT Hospital, Trivandrum. On the topic, are all meconiums cesareans?
Respected chairpersons, senior members of the profession, colleagues, at the outset, let me thank Jayesh sir and his team for giving me this opportunity. The topic allotted for me is, are all meconiums cesarean section? As we all know, meconium-stained amniotic fluid is a really worrisome problem for both the obstetrician as well as the neonatologist. Coming to the incidence of meconium-related problems, the meconium-stained amniotic fluid complicates around 12 to 16% of deliveries, of which the demonstration of meconium below the level of glottis, which we call as meconium aspiration, occurs in around 1/3 of MSAF, about 20 to 30%. And of this meconium aspirated below the level of the glottis, the newborn presenting with symptoms of respiratory distress, when we call it as meconium aspiration syndrome, occurs in only around 5% of these aspirates. And once the baby develops symptoms of meconium aspiration syndrome, the risk of perinatal loss is to the tune of again 20%. Why do I want to quote this change or the gradation of complications is that even though we come across meconium-stained amniotic fluid in around 12 to 16%, by an appropriate obstetric as well as a neonatal care, the last end, that is the perinatal loss, can to a very great extent be reduced. So, what are the risk factors? The basic factors we all know are an advanced maternal age compared to a young females, obesity compared to a normal BMI female, a primigravidas are more prone rather than a multis. Coming to obstetric factors, all factors which can produce a placental insufficiency like preeclampsia, placental insufficiency, growth restriction, oligohydramnios and past date. Intrapartum factors are extremely important, a prolonged PROM, a maternal fever and a chorioamnionitis, which in fact has got a cause-effect relationship because a chorioamnionitis, maternal fever and chorioamnionitis can predispose to MSAF, and MSAF can attract the bacteria and predispose to maternal fever. A prolonged labor with a big baby and a trial of labor, and induced labors are at a more chance for meconium-stained amniotic fluid compared to spontaneous labors. So what exactly is this meconium? Meconium is a greenish yellow fluid normally passed by the newborn within 48 hours of birth, and it is constituted by around 80% water, bile salt, bile pigments, bile acids, intestinal secretions and enzymes, Lanigo hairs and vernix caseosa. Why do we want to know all this? The moment you see that the amniotic fluid is meconium stained, you should know that these contents are the ones which are irritating the uterus, irritating the cord, irritating the fetus. Irritating in the uterus in the sense that these patients can have small irritant contractions. When we see patients with a non-progressive labor contractions in a term patient, we have to have in the back of your mind, it could be the meconium which is irritating the myometrium, the bile salt and the bile acids which are irritating the myometrium. It can cause spasm to the cord vessels so that it can enhance the fetal hypoxia. It can even irritate the fetal skin, and the newborn can sometimes present with what we call as the erythema toxicum neonatorum. It can get aspirated into the fetal lung, which later presents as what we call as the meconium aspiration. So these contents, the secretions, the enzymes, the acids are very much important with regard to the outcome. So is seeing a meconium always pathological? Studies have shown that the presence of light meconium can present a normal maturation of the fetal gastrointestinal tract under neuronal control. However, it is a sign of fetal distress due to acute or chronic hypoxic insults. MSAF is rare before 34 weeks, progressively increases after 37 weeks, and almost 50% of the cases occur beyond term or 40 weeks. So this is again the grading which is familiar to all of us. Just to highlight on the three terminologies, grade 1 is translucent, grade 2 is opalescent, and grade 3 is opaque. So it's easy to remember, just remember the three terms. So grade 1 is translucent, which is light green or yellow. Grade 2 is opalescent, which is dark green or yellow. And grade 3 is opaque with dark green with particulate matter or flakes, which you call as the pea soup type. There is one more classification which has come up recently, is meconium is classified into a non-significant and significant. A thin watery meconium or amniotic fluid is non-significant, whereas thick and tenacious with lumps of meconium, we have to consider it as always significant. So what is the difference between the meconium which is non-significant and significant? Non-significant can occur in a term AGA baby with no maternal risk factors. When the membrane ruptures or you do an ARM, you see the plenty of ample amount of liquor draining and there is a slight yellowish or greenish tinge. And when you put on the CTG, there is no FHR. Then you consider this meconium as non-significant, and it could be due to the GI maturation system, but still you need monitoring of these fetuses. Whereas significant meconium is anything which is moderate or thick, which has got a greater risk of abnormal fetal heart tracing, with an UPGAR which can be below 7 at birth, with a cord pH when you check will be less than 7.2, suggestive of acidosis, who needs a neonatal resuscitation and a level 3 NICU care, higher risk of meconium aspiration syndrome, hypoxic ischemic encephalopathy, respiratory failure, and neonatal sepsis, and even the long-term risk of cerebral palsy. So how do we monitor these fetuses? Definitely we know that monitoring is the key management, and the golden rule in the management is definitely a strict fetal heart monitoring. So how do you decide on whether you need an intermittent auscultation or a continuous CTG? NICE guidelines 2014 mentions that in non-significant meconium, a continuous CTG monitoring is required only if any maternal observations are abnormal or if fetal heart abnormality is suspected on intermittent auscultation. So when you consider it is a non-significant or it is part of the maturation process, you can start off with an intermittent auscultation and you analyze the case if there is an underlying maternal factors like a preeclampsia or a postdatism in which it can be a significant meconium even if it is light in color, where in case you need a continuous. Otherwise you can start off with an intermittent auscultation. Whereas if it is a significant meconium, thorough estimation of assessment of the risk factors is extremely important, and a documented plan of action is essential. A continuous CTG is recommended for all cases as per the NICE 2014 guidelines. So what about your CTG? So you are putting on the CTG. You should know that no particular CTG can be considered as a prognostic value in MSAF. Why? Because studies have shown that MSAF patients 30% can be a normal CTG, 27% can present with a suspicious CTG or a category 1 category 2 CTG, and 41% can have a pathological CTG. So CTG being non-specific, anything else you can add on to identify a acidotic fetus inside. A very simple and reassuring technique is the fetal scalp stimulation test, wherein when you do a PV, in each and every patient we can clinically do this. Now you find out that the liquor is meconium stained. You are doing a PV, you can just stroke the fetal scalp with your fingers and you look at the CTG pattern, and if you see that there is fetal accelerations of more than 15 beats lasting more than 15 seconds, you can be sure that the fetus is devoid of hypoxia at that particular point of time with a positive predictive value of 90%. Next, what else? The fetal scalp blood sampling, which is more authentic in identifying a fetal hypoxia and acidosis by looking at the pH and the lactate. And the cervix is almost 4 to 5 centimeters and the vertex is well low down. You can use a lancet and get a sample of scalp blood. If the pH tested is more than 7.5, you can be assured and you can continue with the CTG monitoring. If the pH is somewhere between 7.25 and 7.2, it is borderline. You will have to repeat the scalp sampling after 30 minutes. If the pH is less than 7.2, definitely the baby is entering into the acidotic range. You will have to expedite the delivery. But the NICE does not recommend it as a routine testing because it is cumbersome, expensive, and hence not routinely recommended. What else? This is just for the postgraduates. They can write as one more additional points in the examination. Fetal electrocardiograph, if you are permitted, you have possibilities for doing it, where you internally record the fetal ECG pattern showing a change in the ST segment and the T wave, which is suggestive of fetal hypoxia. Similarly, fetal pulse oximetry, again over the fetal head, keeping the transducer probe and assessing the SpO2. If it is less than 30% for more than 2 minutes, it's suggestive of acidosis. Now, this is a very important test. Once the baby is born in a meconium stained Leica, we can go ahead with the newborn cord blood sampling for ABG. This can be done from either the arterial cord arterial vessel or the venous, but arterial would be better because that reflects the fetal status better than the venous, which will reflect only the placental status. So in a baby born of meconium, or if the baby appears flabby, it's always important that it's always good if you can do the cord blood sampling, and if the cord arterial pH is less than 7.2, a base deficit of more than 12 millimoles per liter, or if the cord blood lactate is more than 10 millimoles per liter, it is suggestive of fetal hypoxia and acidosis. This has got a medico-legal significance also. Later, when the baby, years later, sometimes the baby presents with, with what you call the cerebral palsy or a mentally retardation. If you have the recording or the documentation that there has not been an acidosis at birth, you are also to a certain extent safe with regard to the medico-legal issues. Now the most debated topic has been the role of amnio infusion in meconium stained amniotic fluid. Years back we used to do this very often. Whenever we see a thick meconium, we take a pre-warmed saline or ringer lactate, instill it through the IV drip until the exit fluid becomes clear. Cochrane review of around 14 papers published in 2014 said that there is a definite reduction in the LSCS for fetal distress, the neonatal NICU admissions, and meconium below the vocal cords if you do the amnio infusion. But later Cochrane data analysis later concluded that there is no significant reduction in the primary outcome. With regard to the baby's outcome in terms of meconium aspiration syndrome, there is not going to be no advantage by doing the amnio infusion, and also the perinatal morbidities and death. ACOG 2012 and 13 also do not recommend amnio infusion to dilute the MSAF. So now, as of now, we don't usually do the amnio infusion just to dilute a thick meconium. So now how and when to deliver? The decision to delivery and the mode of delivery should be based on the overall assessment of the stage and progress of labor and fetal well-being. That means the management should be individualized. If it's a thin meconium, as I've already mentioned, it's supposed to be due to a GI maturational process with no underground or background maternal risk factors or an FGR, and it appears to be very light, the amount of volume of liquor is amply good, then labor augmentation can be tried if they're present prior to established labor according to NICE guidelines. But the liquor should be assessed hourly and the presence of deepening of meconium documented. What we often do is at the time of ARM we document that the liquor is clear, and in subsequent vaginal examinations we often forget to look at the liquor. We look at the cervical dilatation and the descent of the fetal head, we are happy with it. So whatever little liquor is draining between the head and the pelvis, it's extremely important that you look at the liquor in subsequent vaginal examinations also, because meconium can start developing later on in the active phase of labor. So that is extremely important. Hourly, you have to check the liquor in the cloths whether it's getting stained. A thick MSAF, however, LSCS in thick MSAF can be justified to ensure the better neonatal outcome even in the presence of a normal CTG. So the decision for management is MSAF are definitely associated with an increased risk of instrumental delivery and C-sections, but in centers with facilities for electronic monitoring and fetal blood sampling to rule out acidosis, the mode of delivery can be optimized based on the condition of the fetus and the stage and progress of labor. The message that should be carried over is that the mere presence of meconium is not an indication for cesarean section. This is a study which shows that the CS rate is increased much more than the normal clear liquor group. So our primary goal should be identify cases of MSAF. That is what I have mentioned. With each PV and also hourly, you have to identify, try to identify that the LICA has changed from a clear LICA to meconium is extremely important. Identify the risk factors of meconium. In the background, what are all, is this a patient highly likely to go in for an MSAF? We should have a risk analysis of the mother, risk analysis of the intrapartum factors like a maternal fever, or prolonged PROM, or a trial labor with a big baby. These are all risk factors where you have to anticipate the development of meconium during the course of labor. And once you identify and once you have assessed the risk factors, definitely we'll be on the lookout and we'll have intensive intrapartum care with fetal monitoring. We have to optimize the time and route of delivery, and a standardized NICU care with adequate ventilatory support is also extremely important. So this is, in fact, a neonatologist's job, but still, as obstetrician, we should know what has been the change that has come up in the care of a newborn with MSAF. Before 2005, the recommendation was routine intrapartum suctioning, wherein once you know that that is a meconium stained LICA, once the baby's head is out, even before the shoulders are delivered, routinely they recommended the intrapartum suctioning of the oropharynx and the nasopharynx to prevent a meconium aspiration syndrome. That was the consensus prior to 2005. But the 2005 guidelines put up by the American Association of Pediatrics, American Heart Association, and ACOG said that this is no more recommended. So you not suction on to the oropharynx and the nasopharynx as soon as the baby's head is out. Let the baby completely come out and you assess whether it's a vigorous baby or a non-vigorous baby. If it is a vigorous newborn with good respiratory effort and good fetal newborn tone, muscle tone, only essential newborn care by the mother's side is sufficient. But if the baby is non-vigorous with a poor muscle tone and poor respiratory efforts, that guideline said that immediately go ahead with endotracheal intubation and suctioning. But 2015, the guidelines again got updated. The management of the vigorous baby remains the same. You just have to keep the baby by the mother's side and do the essential newborn care. But in non-vigorous babies, now the 2015 says that just seeing that the baby is not vigorous at cry or the tone, doesn't mean immediately you have to put in the endotracheal tube. You can go ahead with the initial steps of resuscitation. And what to mention is that is appropriate intervention based on the baby's picking up of the vitals. So appropriate intervention means that you can even go ahead with a bag and mask ventilation and not just trying for endotracheal in the initial sitting itself. That means you are denying the baby of oxygenation if you are trying for endotracheal. That is what they explain regarding having a bag and mask also immediately prior to attempting an endotracheal intubation. So bag and masking is permitted according to the latest guideline. That is what they say as appropriate intervention. So the principle what they say is resuscitation should follow the same principles for infants of MSAF as those of clear LICA. So to conclude, MSAF is worrisome both for the obstetrician and the neonatologist. The presence of MSAF requires intensive fetal heart monitoring. No particular CTG pattern can be considered to have prognostic value. The decision to delivery and mode of delivery is balanced by the stage and progress of labor versus the risk of developing metabolic acidosis. And thick MSAF, even in the presence of normal CTG tracing, LSCS is justified. These are my references. Thank you. Thank you all for the patient listening.
Thank you so much, ma'am.